I went to my first PRIM&R meeting in 1991, the first year I became director, and have made every PRIM&R meeting since. So this is, 21 PRIM&R meetings, consecutive meetings. But having the network of, because at that time, I think it wasn't safe to say that an IRB director was a professional or an IRB administrator. I certainly see the professionalization of the field over the past 2 decades, particularly that first decade, 91 to, there's many who were in the field in the 80s and 70s. But when I joined, my impression was IRB administrators, directors still had to earn respect. Right. Unless they were at an institution, they established that. But starting out, I think most felt they had to earn that respect. So networking with others and finding how they solved some of these problems, how they handled the compliance cases, to get off the tangent and bring it back, was helpful. And you learn with each one of these. Over the years, I've worked with countless compliance cases. And it's difficult because the faculty members on the defensive, their reputation is on the line, and it's essential that one establishes the right relationship between institutional officials, general counsel, department chairs that are often very helpful in this, and with the faculty member, that you try to strengthen their research program. It bothers me to work through a situation and have somebody be worse off. So a personal struggle was when somebody really was non-compliant and irresponsible. So the non-compliance was due to negligence, due to lack of care, and irresponsibility to know when to act strongly and swiftly, and so that subjects aren't harmed.
So I'm curious, have you noticed any changes in the attitude about research over the years, either from subject's point of view?
Most certainly.
What have you noticed?
Most certainly, and many in our field reference a pendulum swinging back and forth. So many have articulated the pendulum swinging even before when I became in research, from a protectionist era after Tuskegee to the mid-'80s with the HIV epidemic, to a very inclusionary role, and you have activist groups popping up subsequently in breast cancer, in oncology, and brain injury from motor vehicle accidents, stroke. You see all these groups advocating for new advances, and particularly for conditions that standard practice does not offer effective treatment, where research becomes a hope, or the last hope in some cases. There's been a swing from, research is not bad, and it's my opportunity. Then there's another pendulum swing that occurred, and that's the regulatory one, where people were found to not follow either ethical conduct of research or regulatory procedural conduct of research. So sometimes the non-compliance or the misconduct, I don't want to use misconduct in the form of sense that the ORI, Office for Research Integrity, definition of misconduct, fabrication, falsification, plagiarism, but rather just poor conduct. That there certainly was this pendulum swing with the shutdowns by OHRP and the heightened sense of we have to do it better as a research enterprise, and having the stories pop in the press and institutions feeling that their trust from the public is being jeopardized. There were two senses of pendulum swings. One, the subjects feeling like, they needed to be protected. Now they may benefit, and now even the institutions swinging back and forth. Where the late 90s, people were scared, started getting scared at institutions when prominent institutions were being shut down. I don't want to mention them by name because it's not necessary. It didn't matter. It could have happened at any institution. And now, since the turn of the millennium, that has subsided. And there's reasons that has subsided. People have risen to the challenge of trying to do it better. Accreditation has evolved. Remember in the turn of the century, after the IOM reports and PRIM&R's had a couple of conferences really focusing on how can we address these challenges, and accreditation was born. Institutional officials, I think, really started to understand that it was important to conduct research appropriately, and things have turned. And we're in a different era today than we were in certainly the early 70s, the 80s, late 90s, 2000. And there were other factors that kind of also affected this besides awareness to the regs and the benefits of research. There was a cycle in late 80s, early 90s where academic budgets of academic medical centers really got hit hard. Mm-hmm. So resources weren't as available. And I've always articulated with the institutions that I've worked that through the years I learned noncompliance happens from three basic elements. First is lack of awareness or lack of education. Just didn't know that that was the right thing to do. Wasn't aware of a regulation. Another cause of is lack of resources. Mm-hmm. People know, but they don't have the time or staffing to document, and something's found in noncompliance. And the third, which is the rarest, and that is that people just don't care to do it. And in the field, I've been in the field 30 years, seen very few bad apples. Now one could argue conflict of interest could be another one, but I think the three main components or proponents of noncompliance, again, are lack of awareness, lack of resources, and just lack of care to do it right. I came to Columbia in 2003, and I, at the time, came on to direct the IRBs. The position has evolved to develop a human research protection program that meets accreditation standards, and to some extent has backed off from that because the institution has added so many resources to really have an effective human research protection program. So my role as a executive director of the HRPP has really changed over the years as well. Part of it was I certainly implemented a compliance program and oversee the compliance program. We also instituted a robust education training program. Mm-hmm. But since the institution also saw the need for compliance in education and has set up a separate office for it, for the other sister offices that don't have their own compliance and education training. So to assist the grants office or sponsored projects, clinical trials office, mm-hmm. We had a director of compliance and regulatory affairs to help those offices, and we work closely with them. They help us supplement our education training. we handle our own compliance, but there are times where we'll even work with them on some compliance activities that go beyond human research protections. Usually we turn it over. And then there's research billing, and they will have their own compliance function. So as the medical center has added more and more resources to the clinical trials office, which now has an IND/IDE assistance program. And now they have a regulatory affairs person, and the executive vice president for research office has grown, and the vice president for research operations has become more involved. There has been more involvement by institutional officials, which is very positive, on a lot of the issues that I didn't historically see addressed at medical centers. So I don't know that I'm as much really a director of the Human Research Protection Program rather than facilitator for communication to make sure that all the offices communicate effectively regarding human subjects protections. So for the accreditation standards, I would say I am Executive Director of HRPP. What has evolved is to my delight and to a great asset of Columbia is just how each of these offices have now blossomed to really help us in our human research protection program.
So I wonder if you could comment on not any particular place where you have worked with research, but in general, sometimes people talk about how investigators look at the IRB as the obstacle that they have to get over in order to do their research. What have you noticed about that tension?
That tension, based on what I told you about my childhood, would bother me. It bothered me at GW, although it wasn't there much. Felix G., who was a prior director, really set up a pretty strong IRB. The challenge sometimes was resources back then. It was a small office. But I worked hard to have outreach with the faculty and have a collegial relationship. I really wanted to help them. So I didn't hear too much about people being delayed when I was at GW. And what we did to allow the process to be more efficient, we had a monthly IRB investigator meeting. We brought in all the research managers, coordinators, investigators as they wanted to come and meet, and we heard their challenges, and we worked with them to develop tools that would allow them to draft better consent forms. And one stepped up and helped us write our guidelines for writing informed consent. And we actually had groups that would submit, and we wouldn't have to change much. And they would strive. It was a competition amongst the research managers to submit and get it approved upon submission. And that doesn't happen often, but when they did that, it made them feel proud, and they were competitive. And so it was a network of getting them all to work together towards best practices. Columbia, that was a little harder to do because Columbia is larger. And the number of faculty is greater. The departments, I would say, is same in size, but when I came to Columbia, there were a lot of problems. It was very inefficient. There was a lot of non-compliance with the IRB. There were a lot of things that the institutional officials recognized and had started to change a year before I came. So they doubled the staff in 1 year from 15 to 32. They looked for a new director. They called me and asked me to come. I didn't want to come because I liked working at OHRP. I had probably one of the funnest jobs I could imagine. I was division director of quality improvement, and at the end of my tenure at OHRP, I would do quality improvement where I'd go to institutions, evaluate their IRB, and provide consultation how they could improve. And we developed a self-assessment tool that in 40 minutes I could tell where their problem areas were, so it was hard to leave. OHRP. But when I came to Columbia, I came to a system that was had many faults. So when I would meet with faculty, and right off the bat, I developed 2 focus groups, medical center and main campus. I would set up multiple sessions with faculty, representative of different departments, wanted to hear what their concerns were, and I promised them they would see change quickly. And we worked with the staff, changed the customer service immediately, and by 9 months later, most of the concerns started to dissipate. Mm-hmm. So we, once we gained the respect from the faculty, then we had an opportunity or a relationship that we could work easily with them. Mm-hmm. And then we just continued to work to improve efficiency. We were never quick enough for all the faculty, but they saw progress every year, and things have gotten better. We still aren't quick enough, but when you balance everything in terms of compliance with the institution and dean's office wants in terms of compliance, the needs of faculty, and they see that we're balancing between both needs, most are satisfied. It's a need in our country and our nation's research enterprise to really develop public education for the average person out there who doesn't even think of health until they are stricken with some condition. And then it's unfortunate that they're not already armed with information that they should have. So we need, as a nation's research enterprise, to do better outreach. But one thing we need to do is educate people about the benefits of research, what research is, how it's different from standard practice, and to know that it's an option, that they should ask questions, that kind of like consumer product, what's the magazine?
Consumer Reports?
Consumer Reports kind of trains consumers on how to shop for quality. We need to also train the public on how to be a consumer of healthcare and to know what healthcare offers and what research offers. So when somebody mentions research, they know to ask, what is going to happen to me? How are you going to treat it? How would you treat it? Mm-hmm. Okay, now that I understand that, what is this research that you're talking about, and how is it different? And people can be informed. And I could tell you a couple stories from personal experience of how this really can be exemplified. I mean, tell you one story. I got a call on a Sunday night from my 18-year-old cousin. I was at the time a director of GW's IRB. It was probably about 1994. I think it was that year, very close to it. Sunday night, 10 p.m., get a call, and he's hysterical. He's calling from an emergency room, and that his sister was just medevac there from a car accident in which she was thrown out of the front windshield. And she's going into surgery, and a nurse had approached him to sign a consent because his parents were overseas visiting their grandparent with cancer before he was likely to pass away. And he said, I can't believe they're asking me to join some research study. I'm trying to figure out if she's going to live or not. And I said, I'm getting in the car, I'll be right over. Just read me the title of the consent form. He read me the title. I said, who's the sponsor? He told me the sponsor. I knew the drug, I knew the trial. We had approved it in our IRB. I said, look, Frank, this is what's going to happen. Your sister's going in life-saving surgery. You don't have to join the study. But if it was my brother or my mother, I'd be comfortable signing the consent. She's going to get all the care that would be offered to her if she's not in the study. The drug, she has a 50% chance of getting it, The animal studies show, and the studies so far show, that it decreases swelling in the brain. If she gets it, I think it's a good thing. It's not proven, but it's not going to hurt her, based on what I know. And I'd be comfortable doing it for my mother and my own brother. By the time I got to the hospital, she was in surgery. He had signed it. Her head, I saw her, actually I saw her right before she went in surgery. Her head was twice the size of mine when it's normally my size. So the swelling was so extensive. She was unconscious. She had internal bleeding. She had 3 surgeries that night. One on the brain to decrease the swelling. The others in the internal organs in her abdomen. Make a long story short, she survived. She has 2 beautiful children. The one deficit that she has from that accident is that she can't hear 100% from one ear on the side that first hit the road. We never found out if she got the active drug or not. But it would have been so much better if that 18-year-old boy, and I call him a boy because he wasn't an adult to make that decision, would have known how to deal with that. And when we're struck with an emergency situation, and you know, Gigi, firsthand, what it's like to give consent for research, we need to do a better job educating people. Because when they have to make that decision, it's kind of late.
It's too late to catch up.
To make an informed decision without pressure.
Right. How do we educate the general public before they're actually faced with research in the personal?
It's a great question. I think we just have to find ways to get to the media. We have to sensationalize some of these stories. Dateline, 60 Minutes, get some pro athletes involved or something, but we got to grab the public's attention. And it has to be comprehensive. It has to be a grassroots effort in communities, through community groups, having speakers come in. I tried it at Columbia. We went to a community board, and it was well occupied. I was given 3 minutes, and the 3 minutes ended, and people said next. The board said next, because what was more important to them was to know whether their trash was going to be picked up on a given day, or what was going to happen to the parking lot across the street. Mm-hmm. And I don't know that those were the specific things, but there were community issues that they cared about, the appearance of their neighborhood, and it didn't matter to them.
So it's the human condition, I think, that until you're actually faced with the immediate personal emergency, you think it's not important.
Right.
Okay, so
how do we do it? I don't know. But we got to put our minds together and just keep chipping away at it.
Right. Well, then, so we just talked about what does the man on the street didn't know about research. Now I want to really broaden the perspective. Let's just think about the whole human race. And what general attitude or direction do you wish that we as humans would move forward with when we look at research?
I think part of the movement is underway. I think people recognize more and more that it's a noble cause. It's an important cause for society. And just as we see in this country, the amount of medical advances that have occurred in the past 10 years alone, and certainly the past 20 years, yet we have so many health problems in our country and so many health disparities. And we have healthcare costs rising at such enormous pace that we can't afford it. Our health insurance is getting unaffordable. And it's becoming a major economic issue. And we have to address it. Whether we address it with appropriate healthcare reform, we got to make it affordable. So research needs to be considered, I think, not only from the perspective of what good it brings, but we also have to bring the cost-benefit aspect into it, because we could try to extend our lives forever and cure every disease, but we're not going to be able to afford it. And if we can't afford it, we're not going to have a quality of life. So we got to find some parameters on a bigger scale of our research enterprise and find some direction.
Is there a time or is there a situation that you are most proud of what your IRB was able to do, or most proud of how you were able to bring your expertise and shape an outcome?
There are countless incidents where a clinician came to us with an individual case where they believed and submitted documentation of justification that this may save somebody's life. And when we pulled an emergency meeting with 24-hour to 48-hour notice, sometimes between holidays or the day before Thanksgiving break, so on a Wednesday afternoon, on a December 27th, and approved it, and then heard that that patient was discharged. That is, it just chokes you up. That is so rewarding. On a compliance front, when you work with a team that is so scared for their reputation, their jobs, careers, and they end up being a very strong research program 2 to 3 years later, and a model team, and you kept it all confidential, where only the institutional officials knew, the department chair, their colleagues didn't find out, and you walk down the hall and you see them and they smile at you. That's a good feeling. That's a great feeling.
How do you describe what you do to your children? Do they know? Do they understand?
My daughter last year, and my son called me a nerd, which shocked me. They know I do something in administration and research. My daughter, who's now a sophomore in college, has a better grasp of it. My son's an 8th grader, and he has a better grasp of it. But they still don't. They don't get it.
They don't get it?
They don't get it. They know that there's a review committee. They know the general aspects of it.
Mm-hmm. So how do you describe what you do to other people?
If it's outside the professional world, I usually don't talk about it a whole lot. When they ask and insist, I tell them that we're an office that has to approve research with people before it starts to make sure it's safe and ethical and legal. So when a new drug is being developed before it comes on the market, it's tested with people, and we review those studies to make sure it's safe for them, ethical, and then we oversee them, and then we check up on them too to make sure they're doing it right. I turn the conversation to the basketball team that I coach, or the football team I coach, because I'm so proud of it. When I get kids to win together and to believe from sports that they could take that same effort and put it in anything in their life, because I talk to them about careers and that school, and that if they work at something and work with others together, they could accomplish anything. I get so much excitement out of my basketball teams. They win. I don't know what the record is overall over all the years, but we're usually in a championship game or close to it year after year. different ages, different groups. And when you get kids who were losers or didn't believe in each other to all of a sudden perform like that, it's just so rewarding. When you do it with professionals in an office, that's rewarding too. But I like sports. I like to turn the conversation over to that aspect because I like working with kids. I guess over the years, one thing that's been rewarding I haven't talked about is all the colleagues that I've worked with. PRIM&R has offered a tremendous opportunity to learn so much about our field, to shape our thinking, whether it's through the conferences or just the network that it's created. But I'm very fortunate to have worked with a lot of great people out there, and just privileged. I feel very fortunate about a lot of things.
Thank you so much, George. Thank you for sitting down with me today.
Thank you.